Hello, my name is Ian McCall and this is a short talk on the histopathology of basal cell skin cancer. Now, I've commented there that if you're going to be doing skin cancer work, you have to have some idea of the histopathology of these lesions that you're thinking of biopsying and removing. The pathology relates basically to some of the treatments that you're going to use. Superficial BCCs may be suitable for topical therapy, but not so much nodular and certainly not infiltrating or morphic BCCs. And you need to know a rough idea of the thickness of the BCC you're dealing with, because that relates to the penetration of creams such as Aldana and the red light used in PDT, photodynamic therapy. You need to know a bit about infiltrating BCCs and try and appreciate just how deep these things go, and the fact that they may infiltrate around nerves as well. The basisquamous BCC is one that has a mixture of features of a BCC and an abnormal squamous epithelium with features of an SCC. And this business about BCCs getting into blood vessels, metastasizing, is very rare, but it can occur. So let's look at some basal cell skin cancers. First of all, let's look at a superficial BCC. I mean, this is a lady here. You can see she's got several BCCs. She may have had some frozen or treated before, but you've got a lesion here, you've got a lesion here, another small one here, and you've got this larger lesion here. Let's have a closer look at that. Here you can see the pearly edge of the lesion, and in here you get a rough idea of the fact that there isn't a lot of epidermis here, in the sense that there's not a lot of scale. So it suggests that most of this process isn't really involving the epidermis greatly, but it's in fact in the dermis itself. If we were looking at the dermatoscopy of a lesion like this, it would look somewhat like this. You can still see these arborizing vessels, these linear branched or serpentine vessels that are characteristic, and you can see it in this paler stroma. This little portion here is more characteristic of the pallor of the stroma that you in fact can see in some BCCs, and I think there's a little bit of pigmentation in that one. You can see very slight pigmentation around the edges of this as well. But this is the typical picture here that you're going to see with a superficial basal cell skin cancer. So let's have a look, if we can, at the histology of a superficial BCC. We'll take a little look at these virtual slides here. Now, the superficial BCC looks relatively thin, looks relatively flat there. And let's see if we can look at the histopathology of it. We'll see it in full screen, I think. Even at this power here, you can see the blue clumps of cells that are budding from the base of this epidermis. Let's look a little bit closer. Here you can see them, and if we can just go a little bit bigger. Here we go. It'll soon knock into focus. These are the clumps of cells here that are budding off the basal layer of the epidermis. And here you see the peripheral palisading that's quite typically seen around the outer edges of these bundles of clumps of cells. You can see that there almost appears to be skip areas where the epidermis here looks normal. If you're looking with a dermatoscope, then if these were to be pigmented, they would look like blue clods. And it's a classic feature of some pigmented BCCs. So, the major things to note: the peripheral palisading. Sometimes you get a little bit of clefting as well, which is separation of the buds of the groups of cells budding off that basal layer of the epidermis from the underlying stroma. There may be a bit of an inflammatory infiltrate there as well. It's the view of the rest of this specimen. Again, another little area budding off here. The peripheral palisading of the outer layer of cells of these little buds, part of an inflammatory infiltrate here, giving some of the redness, some dilated blood vessels as well. So that's the histology of a superficial BCC. Now, what other types of BCCs might we see? Well, let's have a look at, say, the nodular BCC. Here's a lesion on the face. You can make out slightly the small superficial vessels here. There's another little area here that would be suspicious if you're looking at this man clinically. If you look with the dermatoscope carefully, then this is the picture you see. Here are these dilated serpentine vessels. There's a little blue clot there, so there's a little bit of pigmentation associated with this. And you can see the pearly white material that makes up most of the basal cell skin cancer. When you have this group of cells in the dermis that aren't in fact pigmented, then this is the color that it looks like. We do have some others. Let's have a look at this one here. Here's one on the chin. It's often best seen by putting a little bit of lateral pressure to make it stand out. And then when you look with the dermatoscope, this is the picture you're seeing here. Again, some little serpentine vessels here, but this white or pale stroma of the nodular basal cell skin cancer. So let's put that to one side, and let's see if we can have a little look at a nodular BCC and what it would look like. Okay. Internet's slightly slow tonight. Let's see a nodular BCC. Okay. Again, I think we'll try to see this full screen. Now, when you look at this one, even at low power, you can see the multiple nodules of BCC in this. We don't just have little bits budding off the epidermis. You can see the large nodules of blue cells here. You can see this phenomenon of clefting, of separation of the cells from the nodules from the surrounding stroma. Let's just have a little look at this one. Okay, now it goes into focus now. So again, you're aware of the peripheral palisading of cells here. You know, they're lining up. You can see the clefting that's occurring, and some clefting also around these nodules of BCC. You can see that there is some budding from the epidermis here. So it's a mixture of superficial and nodular. And if there were mainly nodules of this size, it would be called micronodular. You can see that in this presumably shave biopsy, the BCC extends to the base of the shave. If it had just been a superficial BCC, then normally it would be clear. So if we go in just a little bit deeper and look at these, They're usually a fairly dense blue color. Generally, you don't see much in the way of mitoses of cells in a basal cell skin cancer, and generally the nuclei are much the same size and shape. So that's the pattern of a nodular basal cell skin cancer. If that was pigmented, then these cells would, groups of cells with a dermatoscope, would appear as blue clods. Let's just see if we've got an example of that we can bring over. Okay, here's a BCC that's made up of a mixture of different parts. There's a cystic component here. You can see some blue pigment associated here. You can see a pinker portion of the BCC with the superficial vessels. And if we look at the clinical, that's clinical. If we look at the dermatoscopy, again, these are the serpentine vessels. These are the blue and some brown clods, and this was this, which looked like solid to cystic component. Again, the vessels here, again, some other clods. So, what other examples can we show you that we have? That's another more typical cystic-looking basal cell skin cancer. What happens with these is that you get degeneration within the nodules that we showed you there, and a space appears within them. I think there's another example here with the cystic BCC. You can see the blue clods that are part of this as well. So let's see what other, actually, let's see if we've got the other variant that I do want to show. Where's an example I can show you here? Yeah, let's look at this one here. This is the morpheic type of BCC. Here you've got this white scar-like area on the cheek. There may not be much in the way of blood vessels to see on the surface. But if you in fact put the dermatoscope on it, then this is the background telangiectatic picture that you see on his background skin, but within the lesion itself you see these finer branching serpentine vessels in this pale stroma. And this is part of the picture that you can see. They're much paler, obviously, than, say, that superficial BCC was earlier. So let's look at the pathology of an infiltrating BCC. I think probably the best one to see is in this area here. There's several types of sclerosing types of BCC. Let's have a look at this example here. Okay. Now you can see in this specimen here two things. This is your epidermis, a little bit acanthotic there. You've got some cells budding off here. You've got some clefting occurring. But as you go down, these are nodules, but as you go down, you start to get these strands of cells down towards the base of this. There's a lot of stranding there too. And you can see that this is a fairly thick lesion, and yet these extend right down to the base here. And the pink material you're seeing is collagen. It's collagen laid down around these strands of cells. And sometimes the strands of cells may be only 2 to 3 cell layers thick. Let's have a look at some of the others. This is up here at the epidermis. These are some of the cords of cells coming off the basal layer of the epidermis here. There's a suggestion of peripheral palisading of this. You've got some lymphocytes infiltrating into this area as well. As we go further down, you can see these are lymphocytes, these small cells here, infiltrating into this. As we go a little bit further into the depth, then you start to see these thin strands of cells here with the pink collagenous material surrounding them. Again, just to show you that pink material and how relatively thin these strands may be. That's another reason why you can't curette these sorts of lesions, because with curettage you're relying on having a nice solid mass of soft tumor to curette. Here you're going to run up against all this collagen and you're not going to get a nice soft feeling. You're not going to be able to delineate where each of these little areas of BCC are in amongst all this collagen. So curettage is useless for these type of lesions. So this is a sclerosing type of BCC, and if we make that just a little bit smaller, the presenting doctor here comments on nests of basaloid cells merging with angular spiky nests, which these are here, and a desmoplastic or scar-like stroma. That's all this pink material that's in fact surrounding them. And these are the histological features of an infiltrating BCC. So curettage is out. So it can be difficult to get the margins of these lesions. Aldara, PDT are out as well because they will not penetrate down there and deal with these sorts of lesions. So these have to be excised. They have to be excised with good margins, at least 5 millimeters, and they're perhaps best done by Mohs surgery, where the edges are mapped. The whole edge of the excised specimen is mapped histologically, and they give you the best results in dealing with these scar infiltrating or sclerosing types of skin cancer. So, what other type might I want to show you? There's one that we should have a little look at. This is the fibroepithelioma of pincus. It's usually a pink lesion, fairly uniform color, but it has a very characteristic histological picture, a sort of reticulated picture. There you go. These are the reticulated strands of cells budding off this epidermis that you in fact see again, this phenomenon of clefting occurring as well. You might look at that and say, is it a reticulated seborrheic keratosis? Would look different to this. You wouldn't get the degree of clefting that you're in fact getting here. And again, if you look at these cells, these are much more the typical basal cells than the epithelioid cells that you would see. You can have a bit of a myxoid stroma around about these, with a bit of mucin associated with them, but this is the phenomenon of clefting that's fairly typical of basal cell skin cancers. Just a close-up view. And the comments that the doctor has made here. Thin anastomosing strands of basaloid cells creating a fenestrated or net-like appearance, and look for stromal tumor clefting and the myxoid stroma. That just means a mucinous sort of stroma in this material here. If you were to stain this with alcium blue, you would see the blue staining of mucin that may be seen. Other basal cell skin cancers can have mucin in them as well. So that's the fibroepithelioma of pincus, which is a nice one to see as well. I think that covers most of the clinical things that I wanted to show you. Let me just see what other images I have here. There was, let's take this one. Here's a BCC on the back. You can see these bluish areas here as well. Let's just go close up to this. And a little bit of brown here too. I'm not sure if this is perhaps a SEB case seen in association with a BCC here. And if we have, there we go. If we put the dermatoscope on it, there's the typical features of a seborrheic keratosis. And here you have some of the features, some of the fine vessels here, some of the brown clods that you can get in basal cell skin cancer as well. And there's the diffuse background color, slight pink color here too that you'll see in BCCs. Some other clinical cases, there's a very common cystic basal cell. Well, it's probably solid that actually, rather than cystic, just looking at the surface there. And if we look at the dermatoscopy of that, here again, excellent arborizing vessels here, blue clods from that little bit of pigmentation within the lesion. I'm not sure how obvious it is. Yeah, there's some evidence of the blue clods in those areas here. I think we had, what else did we have? Yeah, again, a basal cell skin cancer behind the ear. They can be missed here and they can be very extensive, and this will ulcerate. So ulcerating BCCs are not uncommon as well. I think we might have a histopathology image. We can have a look for that, but I think it's back here. Let's just have a little look at an ulcerated basal cell skin cancer like that one behind the ear. Okay, sorry it's a little bit slow just getting these various things together here, but let's get to the BCC. Now I wanted to have a look at an ulcerating one. Here we go. Let's have a look at this one down here. And again, we'll have a look at this on full screen. There we go. Now, you can see the mass of BCC that you're going to see in a lesion like this. If we can just have a little quick look at the clinical again. I mean, there's a lot of BCC. Look at the edge of this extending up here, and this is the ulcerated area here. It's extending right down behind here as well. So there really is a lot of BCC in this particular lesion. And it would be reflected in this. This is the ulcerated area where the BCC is right to the surface here. The epithelium is gone. And you've got part of an ulcerated BCC here. Let's go a little bit closer to this. Just let that come into focus. Often with an ulcerated BCC like this, you'll have quite an inflammatory reaction too, but just to go over the major features of BCC again. There's the peripheral palisading around the outside. Fairly uniform cells as far as the nuclei goes. Rarely a lot of mitoses within these lesions. If you see a lot of blue cells with a lot of mitoses, you want to have a good look and make sure it's not a Merkel cell carcinoma or a small cell carcinoma of the lung. But you can see how this BCC has ulcerated right through the epidermis. It's gone here. You've got a lot of exudation and scale crust on the area. So this is the histological picture of an ulcerated basal cell skin cancer. Okay, I think we've had a good look today at BCC, ranging all the way from the superficial BCC through the small nodular BCC to the large nodular BCC with a greater mass of cells there, the pigmented BCC, and the more phakic or sclerosing type of basal cell skin cancer. The histopathology varies from each of them. Note the depth of the infiltrating BCC here, and the fact that if you were excising that, you really should use Mohs, but you're going to need somewhere between 5 and 7 millimeter margins to take that lesion out with a 90% certainty that you've in fact removed it. And if you remember that infiltrating strands of cells going down deep towards the fat layer, and perhaps even going around nerves. We didn't show an example of that, but that's another phenomenon that can occur with BCC. Then you get an idea of why a knowledge of the histopathology of these lesions is important if you're trying to manage them properly. Thank you very much.